I was going to wait till Megan got back, but I'll go ahead and start. So for those of you who do not know me, my name is Sean McCullough. I'm a first-year pharmacy resident here, and today I'm going to be talking about C. diff. For disclosures, I will be discussing off-label use of medications. I have nothing else to disclose. And my learning objectives are listed here, and they're provided to you all in the CE handout. And just a note for the CE handout, it's front and back, has 13 questions. In order to get CE credit, I've been required to tell you that you must fill out all 13 questions and answer all 5 multiple choice questions throughout. Okay. Recently, in the past 1 or 2 months, UVA Health System has added C. diff as one of its main Be Safe priorities in order to come up with a solution to this known problem. To give some perspective, some of the other Be Safe priorities that are reviewed are mortality rates, team member energy, patient falls, 30-day readmission. I've listed the rest here. So on a daily basis in the situation room, these Be Safe priorities are discussed. So every single case of C. diff that happens in the hospital is documented and discussed on the following days in order to determine appropriateness of management of that case. And if you look on the UVA dashboard, it shows how many C. diff cases we've had in the past 30 days. And after looking this morning, there's been 50 new cases over the past month. So I'm going to start with a patient case that I adapted from an actual patient case and kind of tweaked it to fit my lecture, but I'm going to be referring to this throughout and using my questions. BM is a 73-year-old male who presented to the ED with progressive shortness of breath and dyspnea on exertion. He was initially admitted to the floor, but was moved to the MICU, where he required intubation. On BAL, enterovirus was isolated. Afterwards, he actually received a one-time dose of ceftriaxone and vancomycin due to fever and low blood pressure. This was discontinued due to viral infection. Of note, he was admitted 3 weeks prior with presumed community-acquired pneumonia, for which he received cefuroxime and azithromycin. On day 7 of his admission, BM was noted to have several loose stools in the past 24 hours. A C. diff PCR was sent, which was positive. His past medical history included lupus, antiphospholipid syndrome. He had a history of diffuse alveolar hemorrhage in 2013, as well as type 2 diabetes. So C. diff, what is it? So it's an anaerobic spore-forming gram-positive bacillus, first isolated in 1935. It comes from the Greek word "closter," which means spindle due to its appearance under microscope, and difficile, which is Latin for difficult, because it was noted to be difficult to grow in culture. So C. diff can be either toxigenic or non-toxigenic. The toxigenic is responsible for disease, and it creates toxins A and B, which are responsible for the diarrhea and the colitis. C. diff is actually a normal constituent of the normal commensal flora, and about 2 to 5% of ambulatory patients actually have it as a normal growing bug in their gut. For healthcare workers, that's closer to 50%, so probably half of us are colonized with C. diff. The spores are resistant to alcohol, heat, and acidic environments, hence why we need to use soap and water when we wash our hands rather than alcohol-based hand washes. And it is transmitted by touch. And interestingly enough, the spores actually can live up to 9 months on hard surfaces. So if patient's rooms, who patient had C. diff and left that room, if it's not cleaned adequately, spores can be left behind. For a brief history of C. diff, it was initially described in the late 1800s, the colitis was, and throughout most of the mid-1900s, it was actually believed Staph aureus to cause this colitis and diarrhea. In 1974, there was a paper that focused on clindamycin-associated colitis. And in this paper, they tested the fecal concentrations, or they tried to culture the fecal matter for Staph aureus, and they weren't able to find any. And it was at this time that it was believed that perhaps it was something other than Staph aureus causing this associated diarrhea. In 1977, vancomycin had been found to be protective in hamsters against this type of colitis. And then a year later, they were actually able to identify Clostridium difficile as the cause of the colitis. C. diff really didn't become a very large nationwide epidemic until the early 2000s, where in Quebec, as well as various hospitals in England and throughout the nation, there was a large outbreak, and this was largely due to the hypervirulent NAP1 strain. So the NAP1 strain, what is it? As you can see, it has 3 different names. They're all the same strain. It's just different methods of strain typing. But it was first identified in 2005, and it was the reason behind the outbreaks in the early 2000s. And so this epidemic strain actually has a higher toxin production than the normal strain. It has a partial deletion of the TCDC gene, and which is responsible for downregulation of toxin production. So the deletion of this gene leads to more toxin production. It is also known to have increased sporulation, and both of these lead to lower cure rates and increased recurrence rates as compared to non-NAP1 strains. So how does it infect us? So the spores are usually ingested by the oral route, where they will actually germinate in our own intestines. Now, this is not enough to have disease, as our normal commensal flora is protective against C. diff. However, if our flora is some way disrupted, such as by antibiotics, it allows the C. diff to overgrow. This still isn't enough for disease. It depends on if the C. diff strain it actually will produce toxin versus not producing toxin. If it is toxigenic producing and is actively producing toxin, it can lead to interstitial membrane breakdown, leading to colitis and the antibiotic-associated diarrhea. So for clinical manifestations, the hallmark symptom of C. diff is a watery, non-bloody diarrhea, where the IDSA case definition of diarrhea is 3 or more loose stools in a 24-hour period. The interpretation of loose, here at UVA in our micro lab, the stools that are sent there essentially must be pipettable, which means that it essentially needs to be liquid. It can't be solid or semi-solid in any form. And I'm sure you all have seen some C. diff PCRs that have been sent and rejected due to the nature of the sample. Other nonspecific symptoms include fever, abdominal pain and tenderness, as well as elevated white count, which can be drastic in some patients, up to 20 to 40,000. But these symptoms do not always present in all infections by C. diff. Main complications that we are worried about would be toxic megacolon. And this actually can present with minimal diarrhea, or if you have a patient that has a profuse infection with lots of diarrhea and they suddenly stop having diarrhea. This is something that you should be worried about, as it can progress rapidly and lead to bowel perforation, which carries a high rate of mortality. Other complications include exacerbation of underlying diseases such as Crohn's disease and ulcerative colitis. In 2011, the CDC did a surveillance study to get a better grasp of the overall national burden and incidence of the disease. And they did this by performing surveillance at 10 separate sites with a little over 11 million people. And they focused on different types of C. diff being community-associated and healthcare-associated. And then they would use this data from the site and extrapolate it using 2011 census data. As for the study itself, there was identified over 15,000 individual cases of C. diff, 66% of which were healthcare associated. As you can see at the bottom, there were higher rates in females, whites versus non-whites, and an extremely high rate in patients aged over 65. Broadening this out to a national scale, the estimated incidence of C. diff is just shy of 500,000 people, where 293,000 had healthcare-associated disease and 160,000 included community-associated disease. However, due to the definitions of the study itself, community-associated also encompassed patients who had outpatient healthcare exposure, which constituted 82% of that 160,000. So essentially, all of that to say, the overall 453,000 patients, 94% of the cases are attributable to some sort of healthcare exposure. Also of note, at the bottom, there's 15,000 deaths that can be directly attributable to C. diff. This brings us to question number 1. Which of the following meets the minimum requirement of the IDSA case definition of diarrhea as it pertains to C. diff? Is it A, 1 loose stool per day for 3 consecutive days, B, 3 loose stools in a 24-hour period, C, 2 loose stools in a 24-hour period, D, 4 loose stools in a 24-hour period, or E, 3 loose bloody stools in a 24-hour period? B, yeah, good job. 3 loose stools in a 24-hour period. So moving on to host risk factors, as I talked about in that 2011 surveillance study, there were higher rates in female and white race. However, studies have yet to find an actual independent these two as independent risk factors. They have been found to be independent risk factors, or I guess dependent, added with age, so elderly female or elderly white race. But just know that there is a higher incidence in these two groups. As for advanced age itself, it has been shown to be an independent risk factor. In the surveillance study, it showed an 8.65 higher risk ratio in patients over 65 versus those less than 65. And studies have shown that there is a higher risk of death after diagnosis within 14 days as compared to the general population. And this may be due to a higher association with the NAP1 strain. As far as other host risk factors, medical-related issues, the severity of underlying disease states comes into play, as well as enteral feeding. So there's been studies that have looked at tube feeding versus non-tube fed patients. And tube fed patients are actually at a higher risk of C. diff, specifically post-pyloric tube feeding. Gastrointestinal procedures also carry a higher risk. For immunosuppression, there is the cumulative incidence in C. diff of allogeneic stem cell transplant patients is around 12 to 21% in most of the studies that I saw. And this is roughly estimated to 15 to 25 times greater risk in the allogeneic stem cell transplant as compared to the general hospitalized population. As for chemotherapy, the incidence rates approach 2 to 7%. And several specific chemotherapy agents have been associated with C. diff, but most of the papers that I found it difficult to either blame a specific drug versus the underlying disease state of cancer itself. Moving to medication risk factors, about over a decade ago, there was some conflicting evidence on whether proton pump inhibitors either increased your risk or did not for C. diff. In early 2005, I listed a study that showed that PPIs were not associated with C. diff. However, the largest study that I was able to find was in 2012. That was a meta-analysis of 42 observational studies with over 300,000 patients, and they found a significant increase in risk of C. diff for patients who used PPIs concomitantly versus those who did not. And a few of those studies actually even showed an increased risk of recurrent C. diff. So that meta-analysis, this is the forest plot from the study, and if you look on the bottom right, the right side is PPIs are harmful, or in other words, that they cause C. diff. And as you can see, most of the confidence intervals are on the right side of that line, meaning that there was a significant difference in that PPIs are a risk factor for C. diff. Moving on to the most prominent risk factor, being antibiotics. 90% of C. diff cases occur up to 8 weeks after antibiotic exposure. And for reasons that we talked about before, disrupting the normal flora, which allows C. diff to grow. Certain antibiotics have been shown to select for resistant strains, such as clindamycin fluoroquinolones. But virtually all antibiotics can increase the risk of C. diff, with the exception of a small few being aminoglycosides and tetracyclines, but we will talk about that over the next few slides. So this slide was a meta-analysis from 2013 that looked at 8 different studies and included over 30,000 patients that focused on community-associated C. diff, and essentially what the goal of the study was to find which classes or individual antibiotics had a higher risk of C. diff, causing C. diff versus no antibiotics at all. And as you can see, the overall risk after any exposure of antibiotics was increased with an odds ratio of 6.91. And then the rest of the list here, clindamycin had the highest odds ratio, followed by fluoroquinolones, cephalosporins, so on and so forth. And at the bottom, you can see tetracyclines did not show an association with C. diff. But I think it's important that we all know that essentially any antibiotic can cause C. diff, and perhaps there may be some that may be bigger causers of C. diff than others. Following this up with another meta-analysis that looked at the similar thing except in the healthcare setting, found that the overall risk for C. diff after any antibiotic exposure was significantly higher. Aminoglycosides, macrolides, and tetracyclines were actually not associated with C. diff. But I think it's surprising, perhaps to some, that on this list, the top of the list is third-generation cephalosporins. I think of all the time, ceftriaxone often gets used empirically. And I think it's important for us to know, essentially the whole list, that almost all antibiotics can cause C. diff. And if you're treating empirically for an infection that may or may not actually be there, just know that these are not benign drugs. this brings us to question number 2. BM is our 73-year-old male who presented with progressive shortness of breath requiring intubation. Enterovirus was isolated on the BAL. On day 7, BM developed 4 loose stools in a 24-hour period, and his C. diff PCR resulted positive. Of note, he was recently treated for community-acquired pneumonia with cefuroxime and azithromycin. His medications are listed on the top right. Which of the following is not a risk factor for C. diff in this patient? It would be A, current PPI use, B, age, C, recent antibiotic use, or D, laxative use. Yes, D, laxative use. If anything, laxative use in this setting may actually increase the risk of overdiagnosis because it can cause diarrhea, which can lead to be tested, which we will talk about now. So this table essentially just sums up all the different diagnostic tests there are for C. diff. Not all of them are used clinically, but I will briefly go through each. On the top is toxigenic culture. This has a very high sensitivity and specificity, but we do not use it clinically due to a very long turnaround time, at least 48 hours. But it is considered the gold standard method, and it is mostly used in epidemiologic studies. The same comments can go for the cell culture cytotoxicity neutralization assay. It used to be the former gold standard, and it's mainly used in studies as it still has a very long turnaround time and does require technical expertise. Most of the hospitals in the nation either use a 2-step test using glutamate dehydrogenase or enzyme, followed by an enzyme immunoassay, or many hospitals now utilize nucleic acid amplification tests, such as PCR here, as a standalone test. For the combo test of glutamate dehydrogenase and the enzyme immunoassay, the bacteria Clostridium difficile produces large amounts of glutamate dehydrogenase, regardless if it forms toxin or not. So initially, this test is run to determine if Clostridium difficile is present, and then in order to determine if it produces toxin, it is followed up as an enzyme immunoassay. Both do have relatively rapid turnaround times, and this is used at other hospitals currently. Here at UVA, we use a standalone nucleic acid amplification test that has high sensitivity and specificity and a relatively rapid turnaround time. And it can actually even detect the presence of a toxin gene. Now, it doesn't detect if toxin is actually present, it just tells you if the bacteria can produce toxin, not if it's actively producing toxin. Some of the disadvantages are that it is the most expensive test, and it still must be used in the correct clinical setting in order for it to be validated. So speaking about that, there was a study that looked at the relationship between clinical presentation and the sensitivity and specificity of the molecular assays as well as other assays. And if you look at the results, it showed that nucleic acid amplification tests showed highest sensitivity but actually lowest specificity compared to other diagnostic tests when considering clinical presentation. So you can see that the sensitivity was high, the specificity was in the low 80 percentile. In the previous studies for PCR, the specificity was found to be around 97%, but this was due to excluding clinical presentation. So why was it so low in this study? 36% of the tested patients did not actually have clinically significant diarrhea, even though they were tested, and 19% of tested patients received a laxative 48 hours prior to stool collection. So essentially this means that there's higher false positives. We're testing stool that actually doesn't fit the clinical picture of an actual disease infection. And this demonstrates the importance of clinical presentation when interpreting assay results. And then again, in 2015, given the fact that they realized that PCR might not be the best way to diagnose, they looked at the value in using a toxin assay following PCR results in determining whether or not PCR positivity mattered, or whether or not the toxin was there or was absent. If you look in the results, there were 293 patients who were PCR positive, but only 44% of these patients were toxin positive, which means they actually produced toxin, actually had disease. If we had these 293 patients here at UVA, 56% of them likely would have been treated because they were PCR positive, but they were actually toxin negative. So we would have treated 56% of that group that likely did not need treatment. Interestingly as well, they looked at, in this study, the outcomes of length of diarrhea, rate of complications of C. diff, as well as mortality rate. And regardless of a patient having a positive PCR or negative PCR, the outcomes in those groups were not different, significantly different. The only significant difference lay between if patients were toxin positive or toxin negative. So this supports the hypothesis that C. diff is a toxin-mediated inflammatory disease. And I think it's good for us to know that because since we use PCR as a standalone test here, it must be used in the correct clinical setting. And as far as this study goes, they actually recommended that a two-step screening process with PCR should happen and that we should screen for toxin assay after PCR. And this study came out in 2015, and so it'll be interesting to see in the future where we take this data and how we apply it here. This brings me to question number 3. So which of the following is true about testing for C. diff? Stool culture is the most common method of diagnosis of C. diff. Colonization of C. diff is very uncommon, and a positive test result should always be treated. PCR is highly sensitive and specific, but its utility is dependent upon the clinical scenario and an appropriate stool sample, or the use of laxative to form a loose stool for C. diff testing is now recognized as standard practice. C, good job. So yeah, C, PCR is highly sensitive and specific, but it is dependent upon the clinical scenario and appropriate stool sample. So moving into the basics of management, one of the first things you should do when you approach a patient is determine if the patient is an appropriate host for C. diff. Do they have recent antibiotic use? What are their comorbidities? Do they have healthcare exposure? What are their clinical signs and symptoms? Essentially the same ways and methodology when you approach any patient scenario. You may also consider local epidemiology trends, if it is rather regional, if there's an outbreak of C. diff, or even within your unit or floor, if there have been higher rates, it can factor into your decision of, is this infection likely? And an important point I want to bring up is the cessation of any non-essential antibiotics after confirmation of diagnosis. So they've done studies in patients who have mild cases of C. diff infection, and stopping the offending antibiotic actually resolved the infection in about 15 to 23% of the patients. To further back up that data, there have been studies that have looked at patients who have C. diff infection, who are currently being treated for C. diff, and they were broken into two groups, a group that had no concomitant antibiotics, or another group that had one or more concomitant antibiotics. And they looked at outcomes of clinical cure, global cure, and time to resolution of diarrhea. In all three clinical outcomes, they were significantly better for the group that was treated and did not have concomitant antibiotics on board. So essentially, all of this, to sum it up, just shows that if you have a patient and they're on other antibiotics, if you can take them off, if the other infection is somewhat empiric, or if it's not believed that they do have a true other infection, it's best to take off that antibiotic, other antibiotics, as there is better cure rates for treating C. diff in the absence of concomitant antibiotics. As far as other basics management of control, infection control includes hand hygiene as well as contact precautions, and then as well as diagnostic confirmation. So in general, you should avoid empirically treating for C. diff unless there's extremely high suspicion or evidence of severe disease that delaying treatment could be a harm to the patient. However, since PCR generally can return within an hour or two, this usually shouldn't be too much of an issue. So moving into the current treatment guidelines. So the IDSA last updated their guidelines in 2010 for C. diff. Of note, vancomycin is approved by the FDA to treat C. diff infection. Metronidazole actually does not have an FDA indication. But for a brief history of treatment for C. diff, so in the 1980s and 1990s, there were two randomized controlled trials that compared metronidazole and vancomycin in relatively small patient groups of 50 in each arm. And in general, they found no difference between metronidazole and vancomycin. And so throughout the early stages, both were considered effective at treating C. diff. Until around 1995, the CDC actually recommended vancomycin use to be limited as they were worried about selective pressure for selecting for vancomycin-resistant enterococci. And since that statement by the CDC in 1995, metronidazole has generally been used as first-line treatment, which is later followed up by other studies which we'll talk about that led to the IDSA guidelines. But as you can see for the treatment, in general, it's broken up by severity, mild to severe complicated. And if it's a more mild disease, you get metronidazole, and then it goes up to vancomycin to combo therapy. And in order to end up in one of the either mild or severe disease, it's based on clinical criteria, and the ones that the IDSA guidelines use are white count less than 15,000 or serum creatinine less than 1.5 times the baseline in order to be put in the mild group. As a direct quote from the IDSA guideline, the criteria proposed for defining severe or complicated C. diff are based on expert opinion. There have been studies that have looked at severity scores and trying to separate patients into different groups, but just know that these criteria were based on expert opinion rather than hard data. So in 2007, there was a specific study that looked at metronidazole and vancomycin in order to determine which was superior for mild or severe disease, using their severe criteria listed here in the methods. And the results are the cure rates. And so between metronidazole and vancomycin, there was no significant difference for mild disease, hence our recommendation for metronidazole being used in mild-moderate disease. But for severe disease, vancomycin was found to be significantly better, which is why the IDSA guidelines recommend vancomycin in severe disease. There were no differences in recurrence rates. As for severe complicated, again, I'll quote the IDSA guidelines. Despite the lack of data, it seems prudent to administer vancomycin by oral and rectal routes at higher dosages for patients with complicated C. diff. So again, these recommendations are not evidence-based, but rather driven by expert opinion, or if you will, fear, the fact that patients who are hemodynamically stable and they look like very ill, the rationale is to get higher doses, higher concentrations, which will hopefully lead to better killing of C. diff. Since the guidelines have been released, though, in 2015, Wake Forest released a study that compared vancomycin monotherapy versus combination therapy with vancomycin and metronidazole IV. What they found was that in the vancomycin monotherapy group for severe patients, mortality was significantly higher in this group as compared to combination therapy. There was no difference in clinical success or length of ICU or hospital stay. But this data actually seems to support the idea that perhaps treating with combination therapy in a severe complicated picture may be rational. Then in 2013, the American College of Gastroenterology came out with their own recommendations. If you look on the far left and far right, the severity and treatment essentially matches up with IDSA guidelines. However, the only thing that changed was their clinical criteria. And so the choice to limit these guidelines to the criteria listed here, being albumin, white count, and abdominal tenderness, was based on a prospective observational study found here, which lists the independent risk factors of that study that the guidelines cited. And so what they found as significant risk factors for C. diff was abdominal distension, fever, a white count over 20,000, and hypoalbuminemia, less than 3. So even from here, you can see that the ACG guidelines that we just saw, they used a white count over 15,000 abdominal tenderness, and they choose to neglect some of these other risk factors. So you can see that these are still based off, in general, expert opinion. Moving on to question number 4. So on days 4 to 7 of BM's stay, he was on an extensive bowel regimen, which included 2 tablets of Senna twice a day, polyethylene glycol 3 times a day, bisacodyl suppository, as well as he was also on mycophenolate and tube feeds. The frequent loose stools prompted the team to send a C. diff PCR on day 7, which resulted positive. The team turns to you for advice on the likelihood of infection. As you can see in the top right are his labs. In general, they're all within normal limits, except the white count is slightly elevated. Vital signs stable, no known allergies. Which of the following is the most appropriate response to the team? Infection is confirmed by PCR, recommend vancomycin PO 250 QID. B, infection is likely given the number of loose stools regardless of laxative use, recommend vancomycin PO 125 QID. C, infection may be present, but the clinical picture is confounded due to the recent laxative use. It is impossible to rule C. diff in or out at this time. Or D, infection is extremely unlikely as BM does not have any risk factor for disease. Yes, C. So as we talked about before, the infection is not confirmed by PCR results, as if it is tested in the wrong situation. It can still be positive and the patient not have actual disease. B, possibly tricky. Infection is likely given the number of loose stools. That is possible, but given the fact of the extensive bowel regimen that the patient was on, that is likely why they had diarrhea, and that is essentially the only reason that they tested the stool for C. diff. And so C is the best. And then D, he recently had antibiotic exposure, so he does have risk factors. So speaking about vancomycin 250, so what is the role of vancomycin 250? I've actually seen it used here, I've seen it used other places, and I've always wondered what the data behind it was, and I couldn't find any. So there actually are no studies that show better outcomes with the 250 milligram dosage of vancomycin. There was one study that looked at fecal concentrations using 125, 250, or 500 milligrams of vancomycin 4 times a day. And as you can imagine, the fecal levels increased in proportion to the dose. However, at 125 milligrams 4 times a day, the concentrations in the fecal concentrations were 500 to 1,000 times greater than the MIC of C. diff. So essentially saying that higher dosages are unlikely to be more effective. And this is from the study. It has fecal concentrations on the y-axis, and on the x-axis is the days of treatment that show the respective groups, green being 500, red being 250, blue being 125. But the MIC is essentially the bottom line of 1. So again, that 125 reaches concentrations way over the MIC, and that 250 really doesn't have great outcome data to support it. So moving on to treatment of recurrence. So of patients that have C. diff infection, up to 25 to 30% of those patients will go on to develop a recurrent episode. Of patients who develop a recurrent episodes, 40 to 60% of them will have a second recurrent episode. So it is somewhat of a vicious cycle of a disease. But the IDSA and ACG recommend that for the first recurrence, you treat it the same as the initial episode, unless the patient presents in a more severe state, such as you treat them with metronidazole the first time they come in, but they look overall have a higher white count, higher serum creatinine, if you will. You may treat them with vancomycin for the first recurrence. As for second recurrences, there have been studies that looked at using a fixed vancomycin regimen versus pulsed and taper regimens, and what they found that there was a significantly reduced recurrence rate of C. diff in the pulsed and tapered vancomycin regimens. And so the IDSA guidelines recommend using these types of regimens. And while there's not exactly a right or wrong taper schedule, I've listed the one here that was used in the studies. Briefly talking about fidaxomicin. So it is a non-absorbed macrolide antibiotic. It actually has no effect on bacteroides, unlike metronidazole and vancomycin, so it is believed to be intestinal flora sparing of the normal commensal flora. And so in 2011, the study that essentially got it FDA approved compared if fidaxomicin was non-inferior to vancomycin for C. diff. And they looked at the primary endpoint of clinical cure, secondary endpoint of recurrence. So on the y-axis, we have patient percent, and then on the x-axis, we have the individual outcomes, being clinical cure, recurrence, global cure. And then under each column, it's ITT for intention to treat group, or PP for per protocol. And as you can see on the far left, the clinical cure rates were not significantly different between fidaxomicin or vancomycin. But if you look at the recurrence rates, fidaxomicin had significantly less recurrence in their patients as compared to vancomycin, which ultimately led to global cure, having a significantly lower or better global cure rates. However, the rates of recurrence, specifically among the NAP1 strain between fidaxomicin and vancomycin, were not significantly different. Now, in the hospitals currently today, we do not test for NAP1 strain. This is more done in methodologic studies. So it can be hard to determine when we should be using fidaxomicin over vancomycin, as it is more expensive, when we cannot determine if it is the non-NAP1 strain that fidaxomicin would be better at recurring infections. So there have been some studies looking at cost effectiveness of fidaxomicin. So looking up on Cardinal's website, the WAC price was about $3,000 for a 10-day course of therapy. And it has been hypothesized that if we could find out how to isolate non-NAP1 strains, maybe it's more cost effective, or just generally in recurrent or severe C. diff. Some of the studies that I found, that there was a Monte Carlo analysis that showed fidaxomicin was more cost effective in terms of recurrences and clinical cure rates. Perhaps the best study that I could find was in 2015. It was a retrospective study that compared either fidaxomicin versus vancomycin. And they assessed costs based on the drug prices, the hospital stay, as well as Medicare reimbursement amounts, and found that fidaxomicin saved about $3,000 per patient hospital stay compared to vancomycin. But also throughout the literature, I've found that there has been studies that have shown that fidaxomicin is more expensive. So it'll be interesting to see the role of fidaxomicin moving forward in determining if it really can be cost effective. As far as fecal microbiota transplant, I won't spend a lot of time on it. There's a lot more data on it recently. But essentially, the ACG guidelines recommend considering FMT if you've had 3 or more recurrences. And the rationale is that as antibiotics broke down your normal commensal flora, if you're able to transplant stool from a healthy participant, you can restore that flora and overgrow C. diff. This slide, I just think it's interesting. So on the far left, shows day 0 of a control and an antibiotic of your normal gut flora. And the blue squares represent bacteria, which are listed here on the right. So you can see on day 0, the antibiotic looks similar to the control. However, 7 days after antibiotics, all the blue squares have now disappeared of your normal gut flora, and some of the other gut flora that usually isn't there has started to be able to grow. So it shows the collateral effect, if you will, of antibiotics on the gut flora. All right, so question number 5. So at the previous admission that we had been talking about, the team decided to treat BM with metronidazole. 3 months later, BM is admitted again with complaints of fever, diarrhea, and abdominal tenderness. He recently was treated with clindamycin for a tooth abscess. The CT does not show any evidence of bowel thickening or colonic dilation. His labs are significant for an elevated white count, serum creatinine of 1.5, and albumin of 3.9. His temperature is slightly elevated, but all other vital signs are stable. C. diff PCR is taken, which results positive. Which of the following would be an appropriate treatment for BM's first recurrence? A pulsed vancomycin regimen, B, combination therapy with vancomycin and metronidazole, C, vancomycin 125 QID, D, FMT, or E, tapered vancomycin regimen. C. So it was treated with metronidazole on his first initial episode. And the guidelines recommend to retreat as the same as the initial episode. However, this time it is a more severe picture, if you will, with the elevated white count, elevated serum creatinine, and fever. But not quite severe complicated. I wouldn't say he's hemodynamically stable, and there's no evidence on CT of toxic megacolon. So the correct answer is C. So briefly, we'll talk about future treatments. So prevention, we're going to look into a little bit about probiotics. And there are also things that go with prevention are infection control and vaccines and under development. We'll also briefly talk about new guideline updates as well as investigational treatments that actually have some data out there for them. So for prevention, perhaps prevention is the best treatment. So infection control, antibiotic stewardship programs, as well as educational programs. I believe with what we're doing here at UVA with our situation room, meeting every day, discussing the appropriateness of the management of our C. diff cases, I think we'll see a lot of changes in those 3 topics moving forward. If there's certain units that are performing more poor in overdiagnosis of C. diff, then maybe educational programs could help them out. As far as for probiotics in general, there's been several studies that have assessed probiotics, and essentially all of them just show conflicting results. The study that I found that had the most positive results was a 2012 meta-analysis that included just shy of 4,000 patients that found the incidence of C. diff was 66% lower with probiotics versus placebo. But again, most of the studies out there are conflicting and compounding that with the concern for quality control of product stability of probiotics, and we don't know how much organism we're getting per dose and what the most effective dose of organism is in each capsule has prevented them, the major IDSA and ACG, from recommending them at this time. If you go to the IDSA website for C. diff, you'll see that an update is in progress. It's actually projected publication is spring of next year. Their projected publications aren't always on time, but I would imagine within the next year or so, we might be able to get a new C. diff guidelines. And I think it'll be interesting to see how they, what they address in this. I believe that they will talk a lot more about diagnosis and preventing overdiagnosis and how to appropriately diagnose patients. And it'll be interesting also to see what sort of clinical criteria for severity scores they have. Also, fidaxomicin came out after the IDSA guidelines, so it'll be interesting to see what role that plays, as well as FMT. So as of last year, there was 240 clinical trials registered with NIH looking at C. diff for treatments for C. diff. There's other antibiotics, vaccines, antibiotic inactivators, which essentially act as activated charcoal, if you will. They essentially prevent antibiotics from working in the gut to preserve your normal flora. I'm not sure how that works. And then toxin antibodies and toxin binders, as well as non-toxigenic C. diff strains that will help overgrow the toxigenic strains. Here's a table of the current phase 2 and 3 treatments that have come out or are currently still in process with preliminary data. So on the far left is the treatment group. In the next two columns show the cure percent in the treatment group versus the cure percent in the control. And the control is designated a letter, either V or M, being vancomycin or metronidazole, as that in the control group. And if you look up and down that list, in general, nothing has been shown to be significantly better for cure percent. However, if you look at the C. diff recurrence treatment group versus C. diff control group, I'll note you specifically the top one, cadazolid, and then about halfway down, serodomycin, have shown some beneficial data, which I'll talk about now. So cadazolid is still in trials, as well as the next drug, serodomycin. But cadazolid is an oxazolidinone antibiotic, like linezolid, that inhibits protein synthesis. It is found to be more bactericidal against C. diff. And in their phase 2 trials, their cure rates were found to be similar between cadazolid and vancomycin. However, all the dosages of cadazolid that were tested against vancomycin were found to decrease the recurrence rate of C. diff significantly as compared to vancomycin. And then I put the clinical trial number in there in case anyone's like really antsy. And then serodomycin is a cyclic lipopeptide that induces membrane depolarization, just like daptomycin. And it is noted to be intestinal microflora sparing, and so far there haven't been any serious adverse events reported. But essentially for their phase 2 trial data, they didn't actually report about the cure percent rates between serodomycin versus vancomycin. But as far as recurrence rates, it showed that serodomycin had a significantly decreased recurrent rates as compared to vancomycin. So essentially I just wanted to bring both of those to your attention to state the fact that there may be some promising new drugs coming out eventually. And with that, I will take any questions. Matt.
So based on that study out of Wake Forest, is your recommendation for all critical ill patients with C. diff to treat with dual therapy? Or do you still use the severity classifications?
I think for severe complicated, I think doing combination therapy, there is benefit shown for it, and I think I would do that at this time. That would be my recommendation, yes. Yes, Mary?
So in your discussion about when testing is inappropriate, using laxatives or patients who are on a lot of laxatives was one of the mentions. So is there, if you had a patient who had significant stool output and they're on significant laxative regimen, at what point would you recommend, how long would you want to have a patient off that before you'd say, okay, now we should send a stool sample?
Well, I think it's tough because it's confounding. I don't think there necessarily is a right answer. But if you stop laxatives, and if the diarrhea didn't remit, I would say over the next day or two, and they're still having profuse diarrhea, I would believe that that wouldn't be from the laxatives at that point, and I would be concerned about C. diff. But I think it is hard because we do have a lot of patients that are currently on laxatives, even if it's minor, just Cinna once a day, and they start having profuse diarrhea. Well, the Cinna probably didn't produce that profuse diarrhea, but at the same time, it probably muddied the waters as far as this could possibly be a C. diff infection. But I guess for your specific scenario, depending on if the patient looked actually severely ill or not, I think it would be best to hold off maybe at least a day or probably 2 days to determine if the diarrhea would remit. Jillian?
So if you had a patient who needed C. diff treatment and other antibiotics, do you ever recommend extending the C. diff treatment, or what? Is there any?
So I've looked into that, and there's no right answer for that either. I've seen other protocols where if you have to treat with concomitant antibiotics and C. diff, treating for C. diff at the same time, they will extend their C. diff antibiotics just after the end course. However, if you have a patient who has osteomyelitis and needs to be treated for 6 months, and then they also develop C. diff, are you going to treat them for 6 weeks? Likely not. So I think the best way is to give them that course of C. diff therapy. If you notice that their diarrhea has stopped, more than likely you have successfully treated it, I think it is appropriate you can stop treating for the C. diff but continue other antibiotics. But that may come up, and you may very well have to extend your treatment course of C. diff antibiotics if they're on concomitant therapy. Thank you.